I'll start it
Okay.
after I broadcast. Good morning, everyone. Good morning. We will get started in just 1 minute once I see the attendee count slow down. Welcome, everyone. I'm about to, excuse me, I'm about to begin the interpretation. You will see, let's see. You should now see English and Spanish interpretation available pop up at the bottom of your screen. Please click the globe, then choose your language, then go back and click again and click mute original audio. Again, now some of you may not be able to hear me, but you can click interpretation, click the globe, choose your language. I choose English. Click again, click mute original audio. That will set you up to be able to hear the feed of the language of your choice. Okay, so good morning, everyone. My name is Izzy Greenberg. I run the Middlesex Coalition for Children and am one of the co-chairs of the Connecticut Early Childhood Alliance. These calls are being sponsored by the Connecticut Early Childhood Alliance. Meryl Gay is with us today, by the Connecticut Association for Human Services, and Liz Frazier will join us in a little while. CSEA, SEIU, and Ava Bermudez Zimmerman is here today, and in fact is acting as our translator this morning. So thank you so much, Ava, for that. And our guest today is Tina Pasco, who is a pediatric nurse consultant and is going to help us wade through the all the questions that we have on health and keeping our children and families and ourselves safe. So actually, Ava, would you be able to give the instruction in Spanish before we begin?
You guys, I'll be on in a little bit. I just have a few things I've got to take care of.
Sorry.
Meryl, are you going to do the federal update?
We're broadcasting now, so just 1 second. Go ahead. Okay, thank you. So I'll just tell you that language setting one more quick time because we've added a new few people. You should see interpretation available pop up. You click that, you choose the language you prefer. I chose English. Then you go click it again and choose mute original audio, and that should put you in the right place. So, okay. Let's see, I'm going to first turn it over to Meryl Gay to give some quick federal updates. Okay, Meryl, it's all you.
Okay, I hope that everybody
We're not hearing
can hear me.
you.
I'm on my phone and it's not
Meryl
working.
has a tricky setup this morning, so we were hearing you before, though.
I don't have a way to
Okay,
talk to you.
Try again.
I don't. Can you hear me now?
Just 1 second. Folks, if you want to just turn your interpretation off for 1 minute, we'll all be able to hear Meryl. He has a funny setup today, and isn't able to work with the language settings. So if you can, even though I just told you to turn them on, you're going to be really good at this. Turn off your interpretation just for 1 minute. And once Meryl is finished, we'll go right back in to interpretation and proceed with the morning. Go ahead.
Okay, so we got some good news on Monday. The House leadership in Washington heard the early childhood community and has increased the amount in the new version of the HEROES Act from $7 billion to $57 billion, $57 billion. That is a, okay, I'm seeing all sorts of people saying they can't hear.
Turn your interpretation off, you should be able to hear.
Okay, so if you turn the interpretation off, you should be able to.
You can also just unclick mute original audio. That will do it as well.
Yes.
If I
Okay.
have English and then I unmute original audio, I can hear him.
So if you unmute original audio.
All right, they can't.
Yeah, they can't hear me, so I can't give instructions. So we have an opportunity. If the House can pass this bill and push it into the Senate, it clearly ups the ante on possible funding for childcare. So if you missed it earlier because you weren't hearing anything, on Monday night, the House leadership issued a new version of the HEROES Act. It drops the total amount from $3.2 trillion to $2.2 trillion. So it's a step towards the Republicans in the Senate as far as a lower total amount. But at the same time, they increased the amount for childcare from $7 billion to $57 billion. And that only happened because of the activism of the early childhood community in Connecticut and across the country. So there will be an afternoon of action again tonight, or this afternoon. I urge you all to call your members of Congress. This is the House members, and urge them to pass the new version of the HEROES Act. And then the other thing I wanted to give an update on, unless Liz is able to do it, is about the census. Liz, are you there? Okay, I'll go ahead and do it then. So you may have heard that the administration in Washington has tried to shorten the census that was originally going to end at the end of October, that they are now, they tried to shorten it so that it ended today. A judge ruled that they couldn't do that. And now the Secretary of the Commerce Department is saying that the census will end on the 5th of October, and it's back in court. But what we know right now is that we have until Monday to finish up the census. There are still thousands of children who, do you want to give instructions again? Because there's still lots of people saying they can't hear.
I think I'm just going to take over, if that's okay.
Okay. Yep.
All right, just 1 second, everyone. Okay, I'm going to guess that people can hear me again. For those of you who, sorry that wasn't working. We don't know what's going on. Sometimes things are just a little bit ghosts in the Zoom. I don't know. So Meryl was saying that there's great news on the federal front that the HEROES bill has childcare increased from $5 billion to $57 billion, which is a huge amount of change, and that change is due to all of the work of the early care community and all of the advocacy from the early care community. So great job, everyone, and please don't, we must be relentless. Please don't give up because this bill is not passed. It is increased, but it is not yet passed. And so, so please stay diligent. This is a time to contact your representatives. Meryl, the request was for you guys to send out another action alert, maybe via the ECE listserv, giving folks the information they need to do the advocacy that is required at this time. The other update was on census. It's caught up in court right now. There's no clear answer as to when it will wrap up, but there's still work to be done. And I'm going to actually ask Meryl to send an email about that as well. Meryl, you could also type that update into the chat. I would say that anything I've missed, if you want to just stick it into the chat to everyone, that would actually be the most effective at this point. And I'm sorry we couldn't hear you this morning. Okay, we are now just going to move along to Tina Pasco, who is our guest this morning. We're very excited to have you, Tina. Thank you so much for joining us. I am going to put the spotlight video on you. So everybody, you will hear my voice asking questions, but you will see Tina. You don't need to look at me anymore. She's the hero here. So I guess before we get started with what she has to say, I want to just say that Tina is a pediatric nurse consultant. She will be able to help us wade through a lot of pediatric clinical information, health information. She can help us with case scenarios, statistics, travel, masks, some environmental stuff, nebulizers, some policies, procedures, the types of things that you guys are probably already working with or have already worked with some nurse consultants on. She is not going to be able to give any financial advice. She's not going to be able to help you figure out how to engineer your HVAC system. So want to say that at the beginning so that we don't get flooded with questions about what HEPA filter to use. That's not going to be something we can cover today. But please do put your questions into the Q&A. And after Tina gives an introduction and some kind of laying the ground information for you all, then I'm going to go into the Q&A. And so please put all of your questions into the Q&A. They can be individual scenarios, but the things I'll probably ask first are things that are going to be most relevant to the widest audience. So if they're very, very detailed and they don't seem things that will be useful to everyone up front, I'll probably move those a little bit down the line. With that said, Tina, I would love to turn it over to you. Thank you.
Thanks. Thanks, Izzy. And I'm so pleased to be here today. I want to thank Meryl for this opportunity and Ava and everybody behind the scenes. I really so appreciate everything you're doing. I was lucky enough to receive many questions in advance, but I'm also available to any other questions or concerns you might have. So I've read through a lot of what your concerns are, and I just want to give you a little bit of history and background about where I'm coming from. I have a lot of years, both at the state level as well as independently as a health consultant. And really my role is not only to give clinical best practice and guidance and standards and algorithms and helping you, but I'm really here for programs to help to navigate, because everybody comes with their own unique needs. They have their own situation, their own individual background, experience, their own health histories, and everything that moves them forward into where we're at today. And I try to help programs to frame it into what their mission statement is and what the statutory guidance is. So I write a lot of policies and procedures. I help programs to implement them. And today I'm here for you guys. So I'm really here to hopefully make a difference and to help you to make some sense out of what sometimes seems like the impossible and senseless COVID-19. So I've done a lot of presentations on the pandemic, what it is. I know you all know it's an extremely aggressive virus when it does hit those that are vulnerable, especially our elderly population. And so basically, it's not one size fits all for your programs. And I help work with all different size programs with all different types of children. And especially my passion is working with children with special healthcare needs and high-end disabilities to try to get them into programs and to make those reasonable accommodations. So during this time, it's extremely difficult for all those nurse consultants that are on this call. I just want to tell you that I've been doing this everyone has a date in their head. Everybody has a date when sort of their world stopped. So in my world, kind of everything kind of ceased. It was around March 13th. It was the day before my daughter turned 21. And she was in Spain. It was like a trip of a lifetime. And she was supposed to go for her birthday. She was supposed to go to Ireland the next day to celebrate this special day. Well, history would have it, the government shut down. She had to catch a red eye, the last flight out of Madrid. And she actually had a friend that could not get a flight out, which was very sad. We finally got her out of the country, but took them several weeks. And, you know, $5,000 later on first class. And my daughter's only comment was, I was treated so well on this flight. It was the best flight ever. They had the best food. They waited on me hand and foot. So that was what started it. And then the very next day, I started getting calls. So there was never there was never a break. It was just, okay, we started getting calls from programs that were doing, working with hospitals. So we were working with Project 26 folks. I worked with a lot of infectious disease doctors at the time. I was working with the hospitals, administration. And the goal was, let's get programs open, let's get them running. Of course, you had to be 5 miles within a radius of a hospital. Let's get the first responders out there. And so we jumped into action at that point. We started creating screener tools, and we were trialing screener tools. That was before any state really had a screener tool out there. We were doing environmental risk assessments. We started nursing orientation to how do you do this screening. And we started looking at protocols around COVID-19. So it was really great because it really, I was there at the very beginning. And I could tell you when I first walked in, so we walked in on our very first program, it was March 19th, I'll never forget it. The nurse with me, she was wearing, full garb, the mask, she had the booties on, she had the gloves, she was ready to go, right? But nobody else had masks on. So from that point on, it just shows you that back in March, programs weren't wearing masks. Several weeks into March, we went into programs, nobody was wearing a mask. But we started screening, and we started to realize that by wearing the masks, and by socially distancing, this was working. So at the time, we were using we were using an otic screener in the ear, we were using a temporal screener on the forehead. So we had to clean between each child. And at the very beginning, we were also screening parents, because we felt if we screened the parent, then they wouldn't have to go to the hospital and then get screened and turned away. We could actually turn away child and parent if they met the screening criteria and they tested out positive and they had a symptomatology, or they had a temperature. So we were able to, and at that point we had decided to use 100 degrees as the temperature. From there, we were, a lot of the programs started to pick up. We had family child care centers. I know at the same time, Dr. Crowley was working on the same screener type tools for all the family child care providers. So a lot of those screening tools were actually being created back in March. So my very first case, it was like my first weekend, had my first case. I screened somebody, they had a sore throat, but they were afebrile, they had no fever. And I did turn them away. Something was telling me, they were fatigued. They kind of had ruddy cheeks, but no fever. Just like short of breath walking up the stairs. And something just said, let's exclude. So we did exclude, and that person tested positive. But at the time, and this was a teacher, and she had been in contact with some of the children, as well as other teachers. But because they had socially distanced, they didn't have the mask, but they had socially distanced. We were lucky that we had no secondary infection. And then since that time, we have tested, and we have turned away, and we have had, quite a few adults, staff members. We've had directors, staff members, we've had family members, we've had people living in the household, we've had grandparents. So we have had test positive. We've had no secondary. So in other words, none of the children tested out positive. Well, back in March, April, May timeframe, they weren't testing, they would test the parents. So if they had 2 test positive parents, they would just immediately exclude and consider that child a test positive, although they weren't doing the actual testing. So how has it changed? So after my second case, I started walking around passing out masks to teachers. I found some additional face protection covering, and I started passing it out to staff members because they were feeling very uneasy about not having protection, knowing that there were some test positives coming back. So at that point in March, we started writing some algorithms, some protocols, and some of them included, what if I screen at home and my child's not feeling well? What are the symptoms? What do I do? What do I do if you're a staff member during the day and the child tests positive during your watch during the day? What do I do? And it is different depending on if you're in an early childhood education program or if you're in the school system or if you're in a special needs school system, because I cover all 3 of those. So there's different case scenarios depending, because some of either comes from the OEC, the Department of Public Health, or information's coming from the State Department of Education. So depending on where the guidance is coming from, we have to, it's all very, very similar, but there are some distinctions, which I could talk about later. So some of the other symptoms, like I said, the main symptoms for folks was the mild shortness of breath, this extreme fatigue, and then we had people with some scratchy throats, ear pain, and that type of, so nobody that tested positive, none of the folks that I've covered, and I have covered thousands of children and their families, and nobody was hospitalized, thank goodness. I do know of people that were hospitalized, but nobody in our programs. But I was always at the very beginning, I was really a proponent of the wearing of masks. And believe it or not, when I first started on March 19th, half of my children in the 3 to 5-year-old group, they were coming in wearing masks already. And I said, wow, and to me at the time, I was surprised. I said, wow, this is just, parent had mask and child had mask, and parents actually preferred that children had masks on. And I know we've come full circle with that. And I know now that it's a mandate, we are seeing, of course, 100%. And I've been around to many, many programs in the state with mask, with the mask wearing since it was implemented that Monday. And I'm really not seeing an issue. We had some issues initially, the first few days. We had a few parents here and there that had some concerns, but we've worked with it. I was at a program the other day. They had a few children on the spectrum, so they didn't wear masks. We have some programs that are almost completely outdoors. And of course, they have the freedom of no mask outdoors. When or we have programs too that have areas where they rest. So they have a designated area in the classroom where it's a mask resting period. And I tried to calculate how many hours most children are wearing masks, because they don't wear them at nap, they don't wear them at mealtime, snack time, or outdoor time. So when you look at the mask wearing time, it's very, very small. If you look at that age group, 3 to 5, we have a lot of mucousy children, right? We've had a lot of teachers that are nervous. They're nervous that the child could be a carrier. Although there's not a lot of data to point one way or the other, I always err on the side of caution. And I think it's comforting for many, many teachers, providers, and families that they know that there is that extra layer of safety. If a child sneezes, that sneeze can travel up to 6 feet, 100 miles an hour. You've got children, they sneeze a lot, they cough a lot, they are very mucousy. We've got seasonal allergies. We have the common cold and rhinovirus. So, and the children don't seem to be bothered by it. Some of the parents are bothered by it, but I think when we explain to them and we just explain that, if one child death is one too many in the state or in the country, one child death. If you can avoid a child getting sick, and I can tell you from experience, I am seeing a healthy population. Why? Because we're self-selecting. We're screening at the door. We used to screen parents and children. So now we're typically screening children at the door, the 5 questions. And then we're also Of course, the parents wear a mask and the child wears a mask, and we're taking temperature. And I really am a firm believer of the temperature, because that's given us another little piece of the puzzle when it comes to excluding children. So I have found that in my own practice, at least I could say that I'm very comfortable with the idea of mask wearing, because it's very limited. And it has been very helpful, and it does keep down that spread, that initial spread of the virus from child to child. We're not seeing a lot of children with colds. We're seeing some time of year. This time of year, we're seeing, still our usual Coxsackie colds, but we're not seeing to the same degree as I'm used to seeing it this time of year. So it is a self-selected group, because we're screening at the door, and the children that are getting into the classroom are relatively healthy. So, or they're excluded at the door, and then we're monitoring and having them call their primary care for additional care. So because of that, I really feel optimistic. And the statistics are also behind us. I just want to give you another example. Let's see, we've had cases where the teacher would come in, the teacher had some symptoms, turned away, not always with a fever, but usually they had some low-grade fever and some symptomatology. We had one where the husband was homesick with a fever, so I turned her away, and they were all tested out positive. But because I myself, as a screener, I kept my distance. I was never in someone's space, which is that 6 feet, for more than 10 minutes, even less. Because I was less than 10 minutes and in that 6 feet time frame, and I actually was not excluded. Even though they were excluded, they were self-quarantining. I did not have to, because I did not meet the criteria for a contact based on the contact isolation criteria. So in New Jersey, we cover some centers. We have 600 children right now, and not one single case in families, in staff, or in children for COVID-19. They've done some testing. As you know, they're testing more children now because they have more tests available, and we're seeing an increase in the number of children tested. They're coming back. I had about 20 children tested, and they all came back negative. It was all, they were diagnosed with rhinovirus, the common cold. So I still get probably on average, I was going to say, about a call. I get a call pretty much every week. And we've been really good at getting them to contact this city and the state health department right away. And I always tell them, document everything. Document what they tell you. Have a list of all of those potential contacts. What classrooms, what teachers, what administrators, who were they with? And so we've been able to really minimize, and I've also been helping with recommendations about covering classrooms, not covering, if you have one person that covers 6 classrooms, and if they meet that contact criteria that I just mentioned, then you're going to end up closing 6 classrooms. So we've tried to be super creative. If they're covering at nap at a distance, and they're away from them, or they have a plexiglass and they're at the door away from them, and they have somebody that's in that cohort closer, then they don't have that same level of exposure. So we've been trying to really do our best in keeping down and monitoring those contact groups, those cohort groups. So I just want to give you a little bit of statistics, some stats for Connecticut as of September 28th. There's been an average of 160 cases, meaning a test positive case per day. And that is a decrease of 27% from the 2 weeks prior, which would have brought us to September 14th. And during this same time frame, there were 2 deaths in Connecticut, not children. So the total positive cases, though, the total positive cases in Connecticut since March has been really up there, 57,147 and 4,503 COVID-associated deaths. Presently, there's 75 that are currently hospitalized. And there's been the PCR tests that they've been doing, the screening, there's been a total of 1,568,802 tests done. So we're doing good. We're doing really well. When I looked at the charts and the graphs, we've been flatlined for quite a while. When I looked at total number of children's deaths, which is sad just to have to look at this, is for less than 29 years old, there were 6 deaths, and then from 19 and younger, there were 2 deaths in Connecticut since the start of the COVID-19 pandemic. But like I said, 1 death is too many deaths. I know, I've really encouraged families of children that are immunocompromised to delay coming into programs. We've had some children that were in the middle of chemo, so I have had them delay their re-enrollment back into programs. So our asthmatic children actually are doing remarkably well, I must say. I don't know if it's because a lot of them are on the steroid that Orapred at home, or they're on the steroid inhaler, but it seems to be that steroid sort of helps those children. And we can talk a little bit too, if you're curious about the nebulizer treatments versus the multi-dose inhaler with the spacer. We had some guidance from the OEC saying we really need to not say no to the nebulizer. There's ways to do the nebulizer safely in the COVID environment. So what we've been doing is if we have to do a nebulizer, which we have very few children that they're ordering it for anyways, but if we do have a child, we can't exclude them or deny the treatment. So some of our asthma children, they're doing treatments outside or on porches or with windows open, but I am recommending that the teacher that administers stay at a distance and wear an N95 mask and the shield, and then also have good ventilation, windows open, or a lot of good circulation. It seems, based on statistics, that we're doing pretty well in terms of our children. So that's always very optimistic. They don't really know why. I mean, there's several theories bouncing around as to why our children are doing really well. They do tend to get a lot of live viruses during the first 12 to 18 months of life. They're getting their measles, mumps, rubella, varicella. They're getting two influenza shots at age 6 months. And then they're also getting their Hep A, usually starting, between the 12 and 18 month period. So we don't know if that's part of it. We also know we really push in our community breastfeeding with our infants, and a lot of of course, breastfed babies are healthy babies. They're getting all that first line, the immunization from the mom. They're getting everything from the mom to really help them to build their immune system. So anyways, from my experience, really what I've been seeing is due diligence, social distancing, mask wearing, cleaning. A lot of my programs are doing the 3 times a day, cleaning, disinfecting. Remember, you have to clean first or disinfecting won't work. We're seeing, even from like high touch items, we're seeing a lot of that going on. We're seeing wiping down playground equipment, which of course we all know doesn't have to happen, but I think that it's a peace of mind to wipe down the equipment with the disinfecting wipes between groupings of children. We're seeing a lot more spacing. We're seeing cohorting. So whatever it is that we're doing, it seems to be working in Connecticut as well as some of the other states that are followed similar practices. We've also been working on, with Dr. Angela Crowley, we've been working on ill child exclusion criteria. And I don't want you to think of COVID in a silo or a vacuum. You have to look at the whole child. We take a holistic approach in healthcare. We're looking at everything. So when you're looking at policy, you're looking at there's hundreds of other diagnoses a child could possibly have. So we are trying to eliminate all of those and treat those other conditions. And if they don't meet any of the criteria for, say, Coxsackie or strep or fifth disease or any of those other illnesses, then we will then look towards COVID. So then we look to ruling COVID. That's why we always say that 72-hour exclusion, it's for a reason. It's to give enough time so that the virus, which can be very aggressive. It's a very aggressive virus, which is a protein, and it latches onto the body and to the organs in the body, and it starts to replicate, and it needs a host. It needs a warm body, so it loves to be in a person. So you really want to make sure you're doing everything you can to protect yourself. But anyways, just think of that when you're looking at your early child exclusion policy. Look at, Caring for Our Children, 4th edition. Look at what we've been doing with the American Academy of Pediatrics, and integrate your COVID-19 folks into that grouping, because you want to make sure you're not missing other illnesses. Like I said, most of the children that have been excluded either had the common cold, or a lot of them are with Coxsackie right now. Or we've had some with otitis media and croup as well. So I'm going to jump to some of the questions. There was one question. Let me see. We had a couple questions. I'm kind of going to group them. Well, one of them actually was best practice and ill child exclusion criteria, but I think I've pretty much talked about that.
Can I just to tell everyone that what I did before this meeting was shared some of the questions that have come in over the last week or two that we seem to not be able to answer or answer well. I culled all of those questions from past meetings and from the ones that you guys sent me last week, and I sent those to Tina in advance. So she has some answers. So I'd say, Tina, you can just say what the question was and your answer, and then once you finish with that, I'm going to get into the Q&A from this morning.
Okay, perfect. So we'll go through some of these questions because a lot of them are groupings. So one of them, like I said, had to do with the ill child exclusion policy and best practice. So yes, I encourage always best practice. Always, go to the highest standard of practice. Even if the minimum requirement is such, it's always best to up the ante here. Like I said, the answer to that really is looking at the whole child and really treating and looking at other symptomatology. A lot of the children, we also don't want to miss any children that have pediatric multi-system inflammatory disease. So that's a biggie, and that's the one that could potentially put a child in the hospital. And those are very clear and distinct symptoms. So they'd have dark sunken eyes, bluing around the eyes and lips, nail bed bluing or cyanosis, of the fingertips and the nail beds, really sunken eyes, not eating or drinking or taking the body, often clammy to touch. And another one of the symptoms would be clutching their chest and chest pain. So we always in the back of our heads want to be mindful of that, because that is a very devastating diagnosis. The other question, and I pretty much have talked about it throughout this morning, is the mask wearing policies that are required. So I've had the pleasure to review many mask policies. And as you heard Commissioner Bai mention last week, there are set policies and protocols and procedures. And there are some templates out there which are really pretty good. So there's several criteria. One, you have to have protocols for how you're going to wear it, how you're going to remove it. You want to make sure it's fitting snugly over the nose and mouth. You want to make sure that if you touch your mask, you're washing your hands. If the child touches the mask, they're washing their hands. That you have a procedure for putting it on and for removing it. If you have times they're taking it off, set times. And then how are you going to do it? Some of my programs are having parents bring in 5 to 10 masks that are, the ones that can be laundered. And they're at the end of the week, they have a dirty bin and a clean bin, and they send them home at the end of the week. So that's really entirely up to the program, whether the parents are bringing them in. Some of my programs, the programs are providing, depending on if they have the resources to do that. And of course, plenty of break times. And we talked about break times already. And then you have to include in there what's the program's response to a parent or guardian who refuses to have their child wear the mask. And of course, it is required right now during this. We're still under the state of emergency pandemic. So when this when this all ends, there is, a light at the end of the tunnel. This will change. So just hang in there, but you really have to work with parents and encourage them, and find out also if there's a medical reason or some other reason where they can't wear it. Because if it's documented, there are exceptions to the rule. Once again, if they have developmental, sensory needs, anything where it's contrary to the child's health and safety. So there is a way around if they have a documentation. So we have, even this week, there were some children that fell into that criteria, and they were not required to wear a mask unless they so chose. And if they did, it was for very short periods of time, just so they would feel like they were part of the group. Other questions, another question had to do with the travel policies. The travel policies are very complicated and they change a lot. So every Tuesday afternoon in Connecticut, I know it's different in other states, but every Tuesday afternoon, there is a release from the CDC and from the OEC, then the Department of Public Health, on all those level 3 and 4 or red states, hot states, states that you have to be mindful of if you're traveling to. And you can ask me more specific questions as well. But there was one, let's see, a person tested positive for COVID-19 90 days before coming to Connecticut. They still are required to self-quarantine and complete a travel health form. So the quarantine is still recommended 14 days. They call it self-quarantine. So how do you determine if a state's in the red zone or they're level 3 and 4, they're hot spots? It's if they have a case rate, a positive case rate higher than 10 per 100,000 residents, or higher than a 10% test positive rate over a 7-day rolling average. Okay, so that has to do with the level 3 or 4 state, and that also applies to countries. So they do say there's 14 days self-quarantine. So what does self-quarantine mean? They say the only time you should be leaving your home or wherever you're at would be to seek medical care, to get your medications filled, or to go to the grocery store and get groceries. I would actually, the third one, be a little cautious with. And also everybody that travels to these states needs to fill out a travel form, which is that ct.gov/travel form. That there's no exceptions to that travel form criteria. So a traveler has to spend 24 hours at least in that affected state. So if you're less than 24 hours, it doesn't apply to you. Also, there are some exclusions if you work in infrastructure with cybersecurity, or your state, local, and federal required. If you're a federal employee and travel is work related and required, but you still have to complete a travel form. Okay, even though I still think that they should be also mindful of where they're traveling to. It also affects households. The question is, have you or anyone in your household traveled over the last 14 days? It does include household. However, there are exceptions, of course. There is, if you get tested 72 hours before you leave that state, 72 hours before you return back to Connecticut, and you stay in self-quarantine until you get the results. So that's an exception. And then you can also get tested when you come back to Connecticut. So self-quarantine until you get the results back from a test. And it has to be the correct test, of course. It has to be the TR-PCR test, which is another way to say reverse transcriptase polymerase chain reaction test. It's a mouthful, but that's the test. So they don't accept the rapid antigen test or the antibody or the antibody test for COVID-19. They don't satisfy the requirements. So they're very, very strict about the test you have to receive. And also you have to prove that your test is negative, and you have to submit that negative test to the commissioner via an email. We could put this up for you, but it's dph.covid travel@ct.gov, or you can fax it. There's a fax number as well. So always remember, check before you travel. Know where you're traveling. If you're traveling for work, know that when you come back, even if you're in the same household, you still would need to get tested and have to be negative before your household members could then either return to school or to work. And there is a fine. There was a question about that. There is a a $500 civil penalty for each violation. And suspected violations are they're supposed to call 211 if you suspect a violation. Let's see. Let me see if there's something. Oh, there's a question about masks if you're on the spectrum. Now, I know there's been a lot of talk about the plastic masks. You could see the mouth and the face and expressions. A lot of our autism children are getting notes they don't have to wear masks. They're getting notes from their provider. But I just want to warn you, we've had a lot of people trialing those for the adults, and they're very uncomfortable. I don't know if they're going to come out with something better, but right now they do tend to fog up. They're pretty uncomfortable to wear. And I also heard that it's very hard to breathe against that plastic shield. The same, the little ones are having trouble wearing those as well. So there are exceptions to children with autism. But just make sure it's clearly documented, so you have something for your record keeping. Let's see. There was questions about, so I think I covered travel. We can look to see if there's any other specific travel questions. There was a question about the types of thermometers. Now, the thermal scanners they pick up the radiation. Obviously, they're picking up from your body. So they're picking up the temperature from your body. But if your body is in cold weather or it's in hot, warm weather, then you're absorbing the heat or the cold, and you're going to get some inaccurate readings. We've been getting a lot of inaccurate readings, either really high or really low readings. So what can you do? You can have a backup methodology. We've had some programs have the thermal scanner, or they have the otic scanner as a backup. Just remember, when you use it, you have to clean it. You have to clean it with alcohol, usually 60, 70% or greater. You have to clean everything between children, of course, but have a backup. Another thing to do is we've had some children that have to wait at the door for 10 or 15 minutes. Then we rescan them. It's pretty inconvenient for families, and it doesn't help with the flow, but sometimes you have to do it to validate that your screening is accurate. So just remember to have a backup plan. Make sure your backup has batteries. So we've had some, you got to use a backup. There's no batteries. Make sure you're calibrating what you have. There's also been some scares out there, social media about radiation. So everything I've read, it said it's really not a non-issue. However, if you are concerned, we do have programs that will scan your wrist rather than the forehead, because I think there's concern with the pineal part of the brain, which is very sensitive, and they're afraid of radiation. Well, it's not supposed to, it doesn't emit radiation. It only picks up what your body's emitting. So it really should not be giving anybody any level of radiation, but we do have programs that will only scan the wrist. And make sure too, another comment is we're required to have 60, 70% alcohol in hand sanitizer. That's a really high percentage of alcohol. So I really recommend that only for providers and not children. We just don't know. We don't want to replace one issue with another problem. Okay, so I would use it even on yourself, very sparingly, but try to have children just get in the habit of washing their hands, the 20-second hand washing. Also, one other thing to remember with this thermal scanner, if you have sweat, if you have cream, lotions on your face, even those with makeup, it sometimes won't give you an accurate scanning. So if you have trouble with the scanner of the forehead, you can do the wrist or the front of the hand, some are doing. So there was a question I wasn't really sure on, maybe somebody can clarify. And thank you, by the way, I see the chat. Thank you for there are some great videos in Sesame Street. So, and there's also a lot of handouts on how to make masks. A lot of the children are actually doing it as a project. They're making them to fit their dolls or whatever. So it can be a really nice teaching experience for children. There was a question about excluding families, and I'm not sure when you say excluding families, I think that had to do with masks. And of course, we don't want to exclude families. We want to work with families. We want to really be we want to be there and we want to handhold, we want to support, because like I said, everybody comes with their own background, their own experience, their own, like, you know, a lot of us personally have had family members, including myself, that were, you know, affected by COVID. So we all have our own individual story to tell. So I think that anything we can do to protect others is really beneficial. Others have been isolated from it, and they may not see what I see. So you really have to work with families to understand and help them to know the importance. And we don't have all the data yet. We don't have all the research yet. We still have a long way to go when it comes to research. So we don't know, is it 100% are masks effective? Well, we don't know that. Children touch their face. We try to encourage they don't touch their mask. We have them washing their hands more. But if they do, if they're very mucousy and they're coughing and sneezing and everything, then it kind of contains that, and we can change the mask and put a new mask on them. And like I said, when you look at a time, it's about 2 hours. 2 hours and maybe a little bit longer total for the day that they're wearing these masks. It's not a lot. And a lot of programs have moved their classrooms outdoors. So if they really want to have no mask, it would be more of those outdoor programs. We do have exclusions based on illness, of course. We do exclude families based on illness. We look at illness in the family. We look at pending COVID tests. We look at positive COVID tests. So if anybody is pending a test, we're wondering why they were tested. So we do want to also exclude the children and the siblings until we get a clearer picture. So, and if there's a known exposure, of course, we do have to look at, you know, the known exposure, the test positive. How long were they in classrooms? Were they with a mask? Did they have symptoms? Were they within 6 feet of anyone at any time for more than 10 minutes? So it's with or without a mask. So the mask really is not a big factor in that, but it does help to contain some of the droplets in both talking and speaking and all those things. So best practice, a question came up on infants. So they have isolated COVID-19 in stool, in tears. You know, there was many ophthalmology reports on that. But it doesn't seem to be a big spreader. But with that being said, I just want everyone to be extra cautious. A lot of, you know, if you're going to be with the infants for a period of time and you're diapering everyone, and sometimes it's best to have one person diapering all the children and one person doing the meal time. So you're keeping those two processes separate in terms of an infection control standpoint. But children touch everything. They're touching their, you know, the diaper changing station. They're touching everything. It's best to wear, you know, a lot of folks are wearing smocks, button down are best. So you're not pulling them over your head and then over your face if you have discharge on them. Also wearing a shield. I mean, if you're going to be with children close up for a period of time where you're doing a lot of care, or they're mucousy, or they're you're you know, giving a bottle, certainly a mask and the face shield is an extra layer of protection, or PPE. And then cleaning all surface areas really well, not just cleaning, but the disinfecting piece. So we do have, like I said, we have families being excluded for travel reasons, and we try to get families back as soon as we can. We try to, you know, do what's best practice for our children. If you have a sick child, you want to have a portion of your classroom away from the other children, and have, you know, monitor from a distance if you can, but so oftentimes we can't do that. So make sure you're protecting yourself, wearing a mask, wearing a shield, whatever you need when you're in close contact.
Tina, do you mind to some of the questions that have come in from today? I know those, I know I sent you a lot of things in advance. Is that?
Oh, yes. I'm getting down to pretty much, pretty much the questions that were sent in. Let's open it up, and I'd love to hear what everyone on the call has to say. And like I said, no questions are silly questions, because I had to navigate and learn and research everything over the last few months. So I'm here to help everybody, and everyone's at different stages, and a lot of people are really super comfortable, and other people are at more the beginning stages of either reopening or opening or closing due to COVID. So
great. So that was a ton of information. And if I ask you a question that you feel you've answered already, I'm sorry if I missed that part. I've been monitoring the Q&A in the chat, and sometimes it zones me out a little bit as I'm going through, but
No worries.
so, but if I do ask a question and you're like, nope, I answered that, we'll just pass by it. So the first one, I know you talked about not using, lotion and other things can affect the infrared thermometer. And is there a place like wrist, crease of elbow, neck? Like, is there a place on the body that might be more effective than the forehead? That might be like, is it better to, open up a coat and do the chest as opposed to the forehead? Or that, so that's
yeah. And the forehead seems to be the most specific and the most sensitive to the temperature. But we've had really good luck with oftentimes the inside of the wrist. So that's another good spot.
okay.
But like from all the literature I read, the head is the best, but like I said, there are some questions. The infrared thermometers, they use what's called a passive infrared sensor. So it doesn't emit radiation, but it interprets radiation emitted in the form of heat, and it picks up wavelengths. So of course, most of your heat is lost from your head, as we all know. That's why we wear hats in the winter. But the next best spot would be the wrist, but I haven't heard of other spots of the body like the chest that are that accurate, because the wrist you have easy access to also.
Do you know, are there any, I haven't seen any, but do you have any awareness of long-term effects of the virus, either on children or adults? I've heard some things where it can like eat away at some of the cells of your heart. I've read things that you can get scar tissue in your lung. I've seen, these things out there in places that seem to be good and, good sources, but can we actually know any of the real long-term effects for, if a child, or can we also know if a child is asymptomatic, does that mean that they will have no long-term effect, or can the virus potentially be doing something in their bodies?
Well, I can speak to it a little bit. From what I've read in all the literature, and I do a lot of reading on the topic and the subject matter, it can, once again, those that get it that are compromised, that have the perfect storm, the genetic piece, other factors, high risk, age, weakened immune system, those that are under care for certain things. When that virus gets, and it is a protein, and it likes to attach to organs, unfortunately, and then it tries to replicate within that organ. So there's several factors. It depends on how long it's been in the system, what body, where it attacked. Some people, it seems to be attacking, and the most prevalent long-term effect has been the heart, from what they know right now from literature. So sorry about my dog. He's got asthma. Anyways, so it can cause inflammation of the heart, and it could cause also inflammation around the lining around the heart, and so that can lead to some long-term heart concerns. So yes, they are looking at that. We've had, I get reports from ICU, folks that I know, folks that I keep in touch with in ICUs. And of course, a lot of the patients ended up on dialysis, and they are still on dialysis. Some have been able to get off of dialysis. It was more acute, but sometimes when it attacks the kidneys, it could cause some long-term effects with the kidneys as well, both the inflammation and the damage to the kidneys. So I have heard of that, and also lung. A lot of the folks that have had more of a severe case, and we're not talking about sort of the asymptomatic carriers, we're talking about people where they actually were symptomatic. They had, they're oftentimes sick for a couple of weeks, and it does seem to attack the heart and lungs. A lot of folks still are reporting shortness of breath because they had some inflammation and a lot of extra fluid in their lungs. A lot of the folks that were in the intensive care unit that were able to, that did survive and leave, they do have some long-term effects. The studies are a little bit scattered, but they are looking at that whole cohort of folks that are affected. So yes, I have not seen anything in children. I know if they had the pediatric multi-system inflammatory, yes. There have those children, and that is a type of COVID-19 virus and how it affects children. And it does cause very severe long-term effects with that. There have been amputations because of peripheral vascular, clamping down. A lot of the children became septic with that, or ended up on respirators. So, I mean, that's the most serious extreme case. And I think I heard of a couple cases in New York and maybe one or two in Connecticut, but but they didn't even call, like back in the day, they didn't even call it that. PMIS is more of a recent thing, but back in the day, they had a lot of children that had those very similar symptoms even before COVID, became known to us. So we don't even know if it's been around for longer than we thought, because we were seeing I was seeing children in practice back in December that had a lot of those symptoms. And at that point in time, they were calling it Kawasaki disease. So it's something, I continue to watch and monitor. A lot of studies going on right now.
Yeah, okay, great. And then one thing I'm also just going to share with everyone in the chat is there was an announcement today, I believe, that the state is going to receive 69,000 rapid tests for use in schools, childcare centers, nursing homes, prisons. I'm putting, and actually the best article I could find on this was from the Boston Globe. So that's the one I'm posting. There may be a Connecticut source that I had to quickly find this, but that will just give you some information. So I just wanted to also share that with everybody. So that's there. Okay. This one, I think it's a quick one. Are air purifiers allowed in an EC setting?
I have been seeing, I mean, the freestanding ones. Yes, I have been seeing them. I'm not sure 100% because they are freestanding. They have a plug. We do try to not have any extension cords or plugs, but I have been seeing them out there.
Someone's concerned with ozone emissions from the ozone filters.
Yeah, that I'm not sure of. I can double check for you and get back to you on that one.
All right, that's all right. Thank you.
I know there's some out there. A lot of folks have tried using UV lights. They've put in new HEPA filters in their system, which are contained. But in terms of the plug-in freestanding units, I have seen some out there. I just worry about some of the other issues around having cords dangling and plugs. And so there are other ways besides the freestanding ones that can be built into your system.
Question about policy to exclude. Someone says 48 hours for fever or other symptoms, but should we consider excluding for longer, more like 72 hours?
I think once again, you have to look at your ill child exclusion policy. So the first thing you do is you call your primary care provider. And what they're going to say is they're going to look at all the symptoms. They'll probably do a Zoom visit. They can zone in and they're going to see that, and then they may have you come in for a throat swab. They're going to look in your ears. Do you have an ear infection? If the child has an ear infection or they have potential strep, they have something treatable, they're going to treat the child. And then it's the same rules. They're going to be fever-free for 24 hours off of fever-reducing medicine. So some of them could be put on amoxicillin and they're home for that requisite period of time, but sometimes they're on amoxicillin for the 7 to 10 days. So they would be returning to school. Every program is very, very different. We have some programs that are still at the 70. They keep everyone out with any symptoms, including fever or anything else that's on that list. And of course, the list has many symptoms, and just one symptom in isolation would not, to me, be a reason to exclude. Like, just because a child has a runny nose because of seasonal changes and allergies, I wouldn't exclude them based on just a runny nose. So when you look at the holistic picture, when you're excluding children, are they sick? Do they present with other symptoms? Are they tugging at their ears? Are they crying when you give them the bottle or when they're eating? Are they extremely fatigued and sleeping and not able to participate? Do they present as if they're sick, or is it just very a little cough or cold or with that kind of thing? So we are seeing different exclusion times. Some of my programs are still at the 72 hours because the 72 hours is when you're observing and monitoring for potential COVID-19 children. So if you if you rule it out, say you rule it out and you're treating something else, well, then the regular ill child exclusion criteria policy should be in effect. It should be that those children are treated as if they're non-COVID. If they have symptoms by day 3 and they've ruled out everything else, so they've eliminated all other sources of the illness, then they look at COVID-19, then they do the testing. However, I'm seeing more and more providers are nervous about it because it's now become available more readily for children, so they're doing more testing. So I've had a lot of children tested for just a simple runny nose or common cold. They've all come back negative. So once again, some programs are 24 for if they know what it is, 24, some are 48, and then some are the 72 if they're suspecting COVID-19. And then I would also expect that they get tested at that point.
There's two travel questions. First is, if you go out of state for the weekend, can you have a test in the state before you leave to return to expedite? And how long do these tests take to process?
Good question. So the state is saying 72 hours. So if it's a long weekend, you would actually have to arrive in the state Friday and get tested Friday morning. And then you have to exclude yourself. And, you know, like I said, they only are allowing that one type of test. That's the most efficient test. So and some of those, and I know they're coming out with some better ones out of Yale, so I don't want to misspeak, but just stay tuned because they are coming out with some really, really highly effective and very good types of oral swabs as well as the nasal swabs. But right now, a lot of folks, it's taking 5 and sometimes up to 7 days to get those results back because they're not allowing a lot of the rapid testing. So if they got tested on Friday, okay, when they arrive in that, the red state or the level 3 and 4 state on a Friday, and they'd have to, once they get home to Connecticut, then they still have to self-quarantine until they get the results back, which could be another couple of days. So yes, it can be done, but that's how you'd have to do it because you have to do the 72 hours. But you also have to report it. So you also have to fill out, I think you posted it. So they also have to fill out the travel form for the state. No matter what, you have to fill out the travel form.
Okay. If going back a few steps, if somebody is going to use those infrared thermometers on the wrist, what would the temperature need to be?
Well, we've been using 100. It used to be 100 for adults and then 100.3 or 100.4 for children, but there was just so much confusion around it, and people were saying 103 instead of 100.3. So we determined early on in the process back in March for all of the centers we've been seeing in Connecticut that we go with 100.
Okay.
And that's supported by CDC. So I would still go with 100.
Great. So Donna Guerrera is pointing out that the travel guidelines are a little bit confusing. And about this thing, if the member of the family travels, she believes that the state guidelines are that only the member must quarantine, not the whole family. But I guess this goes down to like what are best practices in a childcare setting versus what the state, like you can go above. So I'm wondering from you, like, do you have a best practices answer to that as opposed to a legal answer?
Yeah, I always get confronted with that. Really, best practice is that the person and anyone in the family member. So when we do the screening, we say, has your child or anyone in your household traveled in the last 14 days? And that has been our best practice standard going forward. Now, if you want to avoid all that, it says, an affected traveler is exempt from self-quarantine. I'm reading this right from the regs. If they have a COVID-19 test 72 hours prior to arrival in Connecticut or at any time following arrival in Connecticut, the result of such COVID-19 test is negative, and he or she has provided written proof of such negative test to the commissioner via email. The traveler must wait for the results and self-quarantine until that time. They always say the traveler, they never extend it to household members, but if they come back test positive and you've had that child in your program, then they've already infected, they probably that child could be a potential carrier. So best practice is to wait for that test to come back. And you can have it 72 hours before you leave the state. So by the time you get home, you may be self-quarantining for 2 days or 3 days rather than the clock tolling the minute you step foot into Connecticut. Then it's going to be more of a hardship. And you want to be able to minimize the amount of time that you're out. It says that also if the test is positive and the traveler is asymptomatic or no symptoms, they should self-isolate away from all people for 10 days from the date of the test. So that can be problematic, because if you're testing positive and you've already exposed your family, because it's telling you to stay away from your family for 10 days. It doesn't, self-isolate away from your family. I don't know exactly what they want in a separate home, maybe. I don't know. Or so if a Connecticut resident tests positive prior to travel to Connecticut, they should delay their travel, obviously, and consult a medical professional. And the only test they're accepting is the TR-PCR test. And any other test is not acceptable right now. So like I said, I always follow best practice, and that would be best practice, is until you get the results back. And rather than wait 14 days, your whole family, I would definitely get the testing done either 72 hours or when you get back to Connecticut. And I know it's been a huge issue because you can get tested 72 hours before you come back, but then you could travel through several other states on your way back to Connecticut and perhaps get exposed somewhere else in those 72 hours. So a lot of my programs, even if they have the 72 hours, they're also having them get retested when they come back to Connecticut.
Can you speak on the importance of the flu vaccine? I think it's mandatory for children, but not mandatory for adults, but maybe something that you tried to speak on?
Yeah, absolutely. So I highly encourage the flu vaccination, especially now, because that will be a whole grouping of people that will not be sick or be mildly sick with the flu this year. So we can focus our resources on those that are positive for COVID-19 and symptomatic or in the hospital. So we don't want a lot of beds taken up by people with the flu and not getting the flu shot. Now, there are some folks that, for some reason, health-wise, cannot tolerate the flu shot, but we do highly encourage it. So it is required for all children, unless they have a religious exemption at this point or medical exemption. And that was from the end of August. We had the first issue came out until the end of December. So, but we are highly encouraging that, and most of my programs are saying that they want the children to receive the flu shot before November 1st. That's their own policy, because they say it's going to be much more effective to get it early on, because that's when we're starting to see flu cases. So you want to get it the earlier the better. You don't want to wait. Also, in terms of staff, now it's not required in Connecticut that everyone have a flu shot. However, I'm finding most of my programs and all of the Yale community, they're writing it into their HR policy. So on employment, you might have to sign something that says, I agree to a flu shot every year unless you have a medical reason. So many programs are requiring it. We've had some programs, which I think is wonderful. They actually contracted with CVS. CVS has a mobile, portable flu shot clinic now. So they will come to your practice, they will set up, and I saw it for myself. I was there at the same time making rounds. And it was wonderful the way they set it up, and they were there for any staff that wanted the flu shot. They just had to present their insurance card. So if you don't have insurance, there's some places do offer free flu clinics. You have to contact your local health department. They do offer free flu clinics from time to time. But I think that's wonderful that they will come. They don't do children at these at the daycares, but they'll do all the staff. And like I said, they had them lined up and everybody got their flu shot, which I think was wonderful. They never did that in the past. They did it. They used to years ago with Head Start. I remember 10 years ago, they'd have flu clinics at Head Start, but they were doing children then. But now they're doing all of the adults. There are egg-free for those children that have egg allergies. They do have egg-free influenza vaccination. So we do encourage it for almost every child, unless they are compromised because it is attenuated, virus. So it is, at one point it was a live virus that they're getting. So we do, they don't give it to a lot of our children that, of course, have leukemia because they have their bone marrow maybe wiped out. Yeah.
Questions here, and I know we need to wrap up soon, but there's a few questions here that have to do about closing. One case in Spanish that says in a home setting, if a person has contact with someone positive, what measure does the provider have to have? Do you close until the test comes out, or does the person just quarantine? There's another one that says, do you think closing classrooms for 2 weeks if there's a COVID case is too long? Some programs feel by the end of the first week, with all participants having the rapid test results, you could reopen. Why has the 2 weeks mandatory closure been chosen? So one is sort of in the home setting, another seems like it might be in a classroom setting, but have, slightly different scenarios there.
Yeah. So in the home setting, yes, I would definitely, because it is a very small area and you can't really self-quarantine and still run a program if somebody in your household is waiting for a test. So if you had a direct exposure to a positive person, then yes, I would recommend that you get the testing done sooner rather than later. Inform your families that there was potentially, they may have been exposed to somebody, because you don't know, because they may not have had a direct exposure. You don't know yet if that person, because they haven't tested out yet. I would definitely wait till the test comes back for the family child care setting. So, so the 14 days. So the 14 days is like the that is the longest that a center would be closed. Most of my centers are not closed for very long. So what happens is they look at many factors. So when you call it into the city and state, and we do this about once a week, I get the call and I help facilitate it all to happen. And I make sure they document who they speak to and what they recommend, what the recommendation is. So they look at, they look at the symptoms. They look at symptomatology. When did it start? Well, if that person had symptoms on a Monday and it's now a Friday, they're going to backdate the very first day of symptoms minus 48 hours because they probably infected the 48 hours prior to symptoms. That's when they're carriers. Those are silent carriers. So then what they do is they take the 48 hours, they take that 1 week. So now we're already at 7 days. So they would close for a total of 7 days, including the weekend. So technically they would be able to reopen the following after probably on a Monday. They probably not let them open on that Friday. So that would be a 5-day closure. I had one case scenario where the person the person thought she had an ear infection, was being treated. She was in a program for 2 weeks and she had symptoms the beginning of the 2 weeks. They went away. She was on amoxicillin, and then she just wasn't feeling very well. When she told me she was short of breath, I said, you call your provider, don't come in the building, call. She called, she came back, she was tested positive. She had already been on site. Now, none of the children or the other teachers or directors tested out or got sick. She was the only one, but they looked at that whole 2-week period and literally they closed for 24 hours for a deep clean and they were able to reopen. So it all is based on when symptoms began, what were the symptoms and how long out, because not everybody with symptoms thinks they have COVID. They might think they have, I've had ear infections, sinus infections. These are my usual seasonal allergies. That's why I'm constantly, short of breath and I'm mucusy. And so those are the scenarios I've seen. And so I think I've answered that question.
And I want people that
very variable. It's very variable depending on all those questions.
And I'm also sharing, guys, in the chart, the flow charts from Minnesota and South Carolina, which can help you in some of the decision making. If you have any final questions for Tina, now's your chance. We're about to wrap up. There was one question about if there's one symptom versus 2 symptoms versus 3 symptoms. And I think that we've sort of answered that, but I think that I want to suggest.
Yeah, so I know, that comes up a few times a week. And I struggle with it all the time because I'm seeing children with a runny nose and they're being excluded, and that's kind of crazy, but they're all testing out negative. In New Jersey, for example, they have to have 2 symptoms in a category. They have to have a runny nose plus something else. So or a fever. So if you have a fever, hands down exclusion. But if it's a child that we know has asthma and they're getting over being sick and they have a little, cough because of their asthma, then I don't expect you to exclude them. If they are a child that has seasonal allergies and it's well documented and they have postnasal drip and they have a little runny nose, they're not going to be excluded. I always say you have to look at the whole person, not just one symptom in isolation. I think that, and I get good at it after a while. Anybody that's doing screening at the door, you get really good at looking at somebody and saying, we're not letting them in the door. You really get good at it because some of the children, what they look like every day. You know your children. You know when they're healthy, when they're eating, they're happy, they're laughing, they have a little runny nose. They're not sick. They're not presenting as sick. I know there is a chance that some children are carriers. I'm not seeing it. It may exist, but I'm just not seeing it. So, I think that's, one other comment. And there was a question about training. Okay. So you never want to do training where you're going to be in a room close together for a period of time. So the OEC during the state of emergency, the OEC has allowed Zoom trainings for things such as medication administration, Module 1 and Module 2, and also for your CPR, but they want you to do the first aid in person, the return demo. They want you to do the CPR return demo in person. So the skills, competencies, as well as testing in person. Also for your medication, Module 1 and 2, they want you to do the skills set and the testing in person, but the only part that can be done in Zoom is the didactic piece. And that limits your group size, which is a consideration. We've done training, we've done everything from diabetic training, seizure disorder training, diastat training. We've done SIDS, Canadian OSHA, we've done it all Zoom this year. So yes, it is accepted for didactic portions, but you must go on site for sign off. So how do we do it? We typically do it one or two at a time. Like the other day I was doing one student at a time. One teacher at a time. And then they take the test, we do the return, and then we go to the next person because we're cleaning and sanitizing our equipment between each student or each teacher. So just bear in mind, there's ways of doing it. I know that there are a lot of exemptions still. So a lot of these are they're still good. Any of their certifications are extended, but if they do want to get training done, it can be done.
Okay. Who do they contact to get a mobile flu shot clinic for their staff?
So the one that I saw was out of CVS, out of the Hamden CVS. I would start with your CVS. I know that if they have the little urgent care centers within CVS. That's where a lot of those mobile nurses are coming from, and they are nurses that come out, and they do have the issue, and they keep it in a cooler. It's very controlled. They track it. They track the doses and all of that. So I would start with CVS right now. That's what I've been seeing.
Who should they report cases? If they have a case in their preschool, who do they report it to? Is that local health department?
I call both. I always have them call the state and the city, local, state health, because first of all, they're tracking it. And I have found too, and it depends what area, and I don't want to say anything disparaging, but some of the city health departments have been a little more lenient than the state. And I always say, go to the most stringent standard. And so there isn't, they're not always on the same page. So I always have them call both, and I always say to go with the strictest standard, which tends to be the Connecticut DPH, the state level. And also just in terms of contact tracing and all of that, I just have them call both to be on the safe side.
Great. Do you know if anyone is doing an EpiPen refresher via Zoom? And if they're?
Well, most of us are doing it. I know that I know Nurses for Daycare, we're doing them. I know Nurse Consultants, LLC, they're doing them. We've been doing Zoom for Yale University. affiliates, and yeah, so there's many, and just check with your own health consultant, and if they need help with it, I can help them, talk them through how to do the Zoom if they want me to present for them, and then they could do the return demo on site. We have many people that will join classes. If there's like one or two, they'll join the class, and then their own nurse consultant will do the hands-on piece on site. Because it's hard for our nurses to be both doing Zoom, and then if you have 12 people and they're from 12 different centers, it's a lot to get everybody competencies done and everyone's testing done. So there's many groups, organizations, and nurses. Start with your own consultant, and then if you have any questions or you have trouble finding somebody, you can always contact me.
And I'm also putting, there's a few people who have added them in Code One and Learn. And how do people contact you, Tina?
They can either go into nursesfordaycare.com. I could give you my phone number. A lot of people will just text me. You can, I don't mind, 203-500-8453. I get a lot of text messages. I field a lot of questions. No questions are silly, and I can always, yeah, I mean, I'm super busy, so it's not that I'm looking for more business, but I always can find a resource. I can usually direct you in the right direction, or sometimes it's just helping you make your decision on what works for your program, because it's not one size fits all. Every program is just, well, of course, every program's amazing, and you all do such great work out there. And I'm just so impressed, because you'll take something I'll say and you just go with it and you make it so much better. I mean, I'm going to give you one quick example. There's a program where somebody actually built these plexiglass dividers, and they have like a whole screening unit outside. And this is a very financially conservative center. They don't have a lot of money to work with, but somebody was nice enough and made all these nice little screener. They have them between the tables when they're eating. It's just wonderful to see. So many creative things with masks. And I'm just seeing that overall, when I make my rounds, which are very limited because we're not allowed in a lot of the classrooms, but I'm making rounds from a distance. And what I'm seeing is like happy children, happy staff. I'm always greeted very pleasantly. They're happy to see me. I've been welcome into programs. I'm very careful. I keep my distance. I do the best I can from the distance, and I try to do a lot of work as much as I can from home for like care planning and all of that. But I'm just always, I can't tell you enough how wonderful the programs in Connecticut are. I'm always very proud to be affiliated. And when I got a call from New Jersey, they actually said, we heard Connecticut, that the programs, the ECE and the family child care programs are doing an amazing job. So hats off to Connecticut. I'm so proud that I can be a part of this. Unfortunately, it's just a bad illness, but it's good that we're all working together for a common good, which is really our children and families. But you guys are really, hats off. Every time I'm so amazed with everybody out there. They're doing such great work out there. So I want to thank you for your time.
Can I just ask you the one final question before we log off?
Sure. Yeah.
If a program, we know the importance of fresh air in a space to diffuse the number of particulate, I guess, in the air and to reduce the risk. If a center or a program or a home is not able to open windows, is a fan useful in any way, or is that just spreading the room?
Yeah, I really don't think just a fan in and of itself is that useful. You'd have to look into, I know some programs do a pretty good job with air conditioning, with good ventilation, with good filter systems within that air conditioning unit and good cleaning of the unit. Ideally, if you can open windows or get children outside on your playground, a lot of places have put up tents for children outside. Rather than even just opening windows is great. But if you can't, I guess the next best thing would be air conditioning or good ventilation within your home or your building. but really get those children outside. We have some programs that are exclusively outside, except for when they have snack or lunch, because of course we've got the bee problem now, but most of them have all day outside, and they'll nap inside. We've even had some programs where they're napping outside, and they have tents set up. So as long as we have this great weather, well, not today, but for most days we've been doing really well. And yeah, outdoors I'm all for, and kids are doing really well. And most of our children, like I said, they're healthier than ever because it is a self-selected population because we're screening so much. We're doing a really great job at screening, so keep up the good work.
Do you know if OEC has approved a virtual admin of meds training?
Has the OEC? Yes. Valerie Bryant had sent out an email to me. She has approved of the virtual training. So there is no set approved training. Most people have been using the training, medication administration and early childhood education. That was the grant years ago with Yale University and state of Connecticut and all that. So many of them are using that PowerPoint presentation, which back in the day, they're not really approving set training programs anymore, but I know that you want to meet the best practice standard. Most training programs are 5 hours total, but now with Zoom, we've been doing 3 hours of didactic, and then the remaining 2 hours is on site. So yes, they approved, they said it was fine as long as we're doing the on-site component. If you don't have the on-site component, it is not an approved training through Zoom.
Okay, thank you so much. And I think we're wrapping up now. We're at 11 o'clock, so we're going to finish. The one thing that I will tell everyone, I'm going to go back to me for a second here. We have put all the links to some sample policies, to those Minnesota and South Carolina flowcharts, all of those things. They're all up on the website. I shared the link. I can share it again one more time. I'm working on getting the language, the Spanish rather, for the website. I thought it had automatically translated, but I'm looking at it and it doesn't have that setting. So I'm going to see if I can figure that out. I also wanted to say that one of the things we are working on for the future is having some folks come on who can share creative, safe best practices for having kids outside more in winter, because I know that a lot of centers and programs are usually have the kids out in a limited capacity in the winter, and we're going to need to do more of have them out more this year. So we're working on having someone come on to help us with that soon. So Tina, I just want to say thank you so much.
Oh, you're most welcome. Thank you. I so appreciated the time, and just keep doing the great work. I'm here to support all of you. Thanks.
You can see coming in the chat, folks are really, really happy to have heard from you today. And the information is so, it's really, and to all of you out there, it's really about us all sharing our best practices with each other. It's all about this community coming together to help each other out, because we're all learning together. So thank you all for being here. We will post the recording of this on the website. I can do it within the next half hour. And so that will be up if you want to share it with other folks you think this could be helpful for. So thank you, everyone. Again,
thanks, Izzy.
Wonderful weekend, and we'll see you all on Monday.
Bye-bye.
Bye-bye.